Good morning. Welcome once again to our webinar series entitled Frontline Report on COVID-19 Vaccines. This webinar series has been made possible via collaboration between the Autoimmune Hepatitis Association and the Center for Autoimmune Liver Disease and Cincinnati Children's Hospital. My name is Craig Lambert. I'm the Executive Director for the Autoimmune Hepatitis Association, and I'm also an adult hepatologist at Indiana University. I am excited to introduce you to this webinar entitled A Dose of Knowledge. Quickly, a disclosure from the AIHA. This series does not replace your primary physician, gastroenterologist, or hepatologist. We cannot diagnose, treat, or manage symptoms associated with AIH. We believe any changes in treatment or therapy should only be done under the supervision and direction of your treating doctor or care team. In this webinar, we are lucky to have time once again with Dr. Robert Frenck, a professor of medicine and infectious disease expert at Cincinnati Children's Hospital. He is an extremely well-published clinical scientist, chairman of the local Institutional Review Board, a principal investigator of an NIH-funded vaccine unit, and has led and completed numerous clinical trials with vaccines targeting a variety of viruses and bacteria. Despite many across the US wanting a novel coronavirus vaccine, there are people that remain hesitant, even if they qualify for vaccine right now. For example, much to my own disappointment, there have been numerous reports of healthcare workers and even first responders unwilling to take it. This, despite clear scientific evidence that these products are safe and effective. We are hopeful that programs such as this one today will not only reassure our members, but even the general public on the importance of vaccination. Before we get Dr. Frenck's input on the current vaccination landscape relevant to autoimmune liver patients, I want to welcome our moderator, Aaron Anderson. As many of you know, Aaron is the Director of Programming and Advancement for the AIHA and has helped to curate a number of members' questions for this webinar today. Thank you for joining us, Aaron.
Lambert and Dr. Frenck, thanks for being with us today. We've received so many questions from AIH patients about the vaccine and whether it's safe for them. And we're just so grateful that you're willing to share your expertise with us and be part of this webinar. Well, we'll go ahead and get started with our first question. The COVID vaccines were developed at record speed, and some patients are really concerned about this. How do we know the COVID-19 vaccines are safe?
So one of the things that I've seen is that I know why they used the name Operation Warp Speed, because they were trying to convey the idea that we're moving quickly. But I think that made people concerned is that we were moving too quickly and we weren't paying attention to safety. And that's just not true. Is that the clinical trials went through the same exact regimen that we would do with any other clinical trial. Really, the only difference this clinical trial and others is that this is the first one where the newspapers or TV or internet or whatever has cared what we've done. Is that so that typically is that we're doing our work, and then when we have a product, we're getting it out to the medical community. But this is like being done under a microscope, if you will. So that's really the biggest change from our typical work. We did the same exact safety. We're doing the same exact observation. The things that's happened really though is that things have been telescoped, if you will. Is that so? Give you an idea is when we enroll a participant in a study, we have a certain number of days to get things into the computer, to be able to send it into the sponsor to review. And usually that's in the 1 to 2 weeks that everything has to be done. For the COVID, we have 24 hours. And so basically people are working around the clock. For the serum samples that we get to see how well the vaccine is stimulating an immune response, or if there's any safety issues and things like that, is that oftentimes we will batch those and send them in maybe every 2 or 3 weeks. Now we're sending them in 3 times a week. So that again, that you're telescoping, bringing things to much quicker. That the FDA, the Food and Drug Administration, typically will get the data on a vaccine at the end of a trial after all the data have been accumulated, and then they submit it to the FDA. What's been happening here is the FDA has been getting batches of information almost in real time. And so that's what has allowed them then to be able to give an answer more quickly, because they already are familiar with the data. It's not like they're just getting dumped a big bunch of data and they have to go through and understand the data. Here, they've been getting it all along. So I would say that we have been doing the same things. The other thing, as known as regular vaccine trials, The other thing is that to kind of give people a bit of confidence, I'd say, is that people say, well, look, 2 of the vaccines, they had to have a pause. I would actually say having the pause is an indicator that we are paying attention to safety. If we weren't paying attention to safety, we'd have said, to heck with that. We'll just keep going. Everything's fine. But that's not what we did. We said, there was these adverse events. We want to check on them and see, is there a relationship to the vaccine or not? Do we need to change anything? And that's why the studies were paused for a few weeks to be able to look at all this. And the conclusion was that this looks like it was a coincidence. As far as for the case of the transverse myelitis, which is a very rare neurological condition, is that they had 2 cases in Great Britain in the vaccine group, but they also had 1 case in the control group. And so this is a disorder, the transverse myelitis, that can happen naturally, is that a virus called an enterovirus can cause transverse myelitis. So it looks like probably what happened is that there was an enterovirus circulating in Great Britain at the same time they're doing this vaccine trial, and the 2 overlapped. And that what I can tell you too is that in the studies where for the AstraZeneca vaccine in the United States, there's been almost 40,000 people enrolled now. They haven't seen any recurrence of those symptoms at all. So it really, at this point, at least looks like it was a coincidence of intersecting events. So that I think that's the best I could say, is that we haven't cut corners. We've enrolled an extraordinary number of participants. Having 30,000 people in a phase 3 trial is huge. Normally, you're enrolling 3,000, 4,000, 5,000, maybe something like that. 30,000 is a huge trial. And we're doing that for each one of the vaccines that we're testing.
That's really reassuring, and I know it makes me feel better about getting the vaccine to hear all those details and know that no corners were cut. I'd now like to talk a little bit about the side effects of the Pfizer and Moderna vaccines. Can you share some of the more common side effects
Sure.
and perhaps what percentage of patients typically get these?
Sure. So that the most common, so a lot of people are getting nothing. To give you an aside, is that we were doing a initial study, a phase 1 study, where we were testing different doses to try and find out which dose we wanted to go forward in the phase 3 study. And in that early study, 4 out of 5 people were getting vaccine. And so my colleague at another institution was just kind of curious, and he was asking people when they came back, okay, do you think you got vaccine or you think you got placebo? And almost everybody said, oh, I think I got placebo because I didn't have any side effects at all. And we know that 80% of the people got vaccine, right? Because that's the way it was designed. But people are going, oh, I don't think I got it. And it was actually, it's kind of interesting is that we've had some mom, we were doing trials recently in adolescents where the mothers have said, okay, I know I shouldn't be happy about this, but my son had some headache, my son had some fatigue and a little bit of fever. So I'm really kind of happy because then I know we got the vaccine. I said, okay, that's not what we're striving for. We want you to have immunity, but we're not, having the side effects. But like I say, many children or many adults are having nothing. But if they're going to have side effects, the most common things are local. I can tell you personally, I received the Moderna vaccine a couple weeks ago, the first dose, and I rolled over on, I got on my right arm, I rolled over on my right side while I was sleeping, and it woke me up the first couple nights. I mean, it hurt, but it was just local. I could still use my arm and everything, but if I hit right at that area, I said, ooh, I know where I got that shot. So that's the most common thing, some pain or redness at the site. And then if you're going to have any systemic effects, the most common by far have been headaches and fatigue. Some people have been getting some aches, body aches, muscle aches. Some people have had chills, and less than 10% have had fever. And even the fever has been low, is like 101 or less typically. So you don't feel good, but it's not been like sending people to hospital or people missing work and that kind of thing. But on the whole, people have tolerated these things well. If you're going to get an adverse event, what we've seen is they typically start 1 to 2 days after the vaccine, and then they're lasting 1 or 2 days. Again, the way that you could think about this is kind of like that one mom I was telling you about, is that this is showing that the vaccine's working. The vaccine's stimulating our immune response. It's getting our cytokines revved up and making our body immune to the virus. So while we would prefer to have a vaccine that has absolutely no side effects, if you look at the benefits of the vaccine versus the risks of the vaccine and the risks of getting COVID, the benefits of the vaccine are far outweighing the risks.
That's helpful information. And I think especially for those of us who work, it's good to know what symptoms we could expect. But I think it's also really important to know that just because someone doesn't have symptoms doesn't mean the vaccine is not working. And there's been,
you know, so actually, I'm sorry to cut you off. As far as that, one of the things now, so that in our clinical trials is that if you're eligible to get vaccine in the clinical setting, so that, you know, you're a healthcare worker, whatever, and your state has said that you can get vaccine, is that we're then unblinding the people in our studies because they need to know whether or not they need to get vaccine or not. We've had, at least at this point, 15 people that have sworn they had placebo, absolutely certain they had placebo, that had vaccine. And so that, and actually, unfortunately, some of them, even though we had pleaded with them, please don't do anything until you get the results, had already gone off and gotten another vaccine because they were absolutely certain that they had gotten placebo. So having the reactogenicity, I would say, yeah, I pretty much can tell you which thing you got. But the lack of reactogenicity, the lack of side effects does not mean that you got placebo.
That's really reassuring to hear. And I know a number of our members will be really appreciate better understanding that. You talked about how the vaccine is safe for the general population. Can we talk more specifically about whether it's safe for AIH patients to get these vaccines? And is one vaccine safer than the other?
Right. So none of the vaccines that we're testing in the United States are what I would call a live virus vaccine. If you have an immunocompromising condition, we typically will stay away from a live virus vaccine. You know, like if somebody has HIV, we'll still give them a measles vaccine as long as they have a decent amount of T cells. But on the whole, we stay away from live virus vaccines if somebody has a suppressed immune system. But I would not think of the adenovirus really as a live virus vaccine in this case, because it's been engineered in such a way that it can't grow in our body. So I don't think that's really an increased risk for people with immune compromising conditions to get any of the vaccines that are being tested in the United States against COVID. But if you wanted to say, I want to be extra special, careful, the mRNA vaccines, there's absolutely no way that they're going to cause you a problem any more than you or me or anybody other, that because it is just the mRNA. There is no virus in there. And none of these vaccines contain the full COVID. None of them can give you COVID.
That's really reassuring. What about the effectiveness of the vaccines for those who are taking immunosuppressants like azathioprine, which is a common medicine that our members take?
So the clinical trials are designed to really test a product in a group of people that don't have other problems. We do that in the first place because we want to minimize the risk to people. So I can't give you data to say that in this group that have had this medication or this group has had that medication is immunosuppressive, that how the vaccine works. What I can tell you is that I think the worst I think that would happen is that the vaccine may not be as effective, is that if you're having some of the immunosuppressions, is that suppressive medications, I think it's not going to increase your risk from the vaccine. It just may not be as protective. Now, I don't know that. It may be just as protective, but that would be the worst case scenario, is that it may not be quite as protective. The main immune response we still have is B cell response. So if you're taking rituximab or something like that, that could potentially, or other things that would decrease your B cells, that potentially could decrease our ability to respond to the vaccine. For the T cell portion of the vaccine is if you're on high dose steroids, that possibly could decrease your T cell response to the vaccine. But like I say, again, the main thing would be is that you might not get as good a take, but there's not going to be an increased risk of safety. And so the way I would look at it is that it still is very important to get the vaccine, and you still will get, I think, some protection, and you may get the exact same protection as everybody else, but I just can't tell you for sure because it hasn't been tested in special populations yet.
One patient wrote into us and noted that at least some doctors in England are actually taking their patients off azathioprine before they receive the vaccine in hopes that the vaccine will be more effective for them. We haven't heard of this happening in the US at all. Any thoughts on this?
So everything we do in medicine and everything we do in life, whether we think about it, has a risk-benefit ratio. Every time we get into a car and drive to work, we have the risk of having an accident. We have a risk of having a serious accident, but we really don't think about that. We just say, okay, that's just part of life, and we just keep going on. So everything we do has a risk benefit. So what I'm getting at with this, as far as then, I would say you have to measure the risk of decreasing your medications for your medical issue versus the the benefits you'd have for the vaccine. So, you know, I would have to leave that one to the hepatologist to say what kind of a risk am I putting somebody at by decreasing their immune medications, because I certainly wouldn't want to do something that's going to make their liver worse, right? You know, so but that would be the risk benefit ratio that your doctor is going to have to go through to say, okay, if I decrease the medication, that may increase the effectiveness of the vaccine, but what's the risk I'm going to have to the person by decreasing their medications for that period?
Great. That sounds like it's definitely something that patients should talk to their doctors about.
Absolutely.
And as an organization, we always recommend that patients never start or stop their medication before talking to their doctors. But we just thought that was an interesting point that member wrote in about.
And I wouldn't even be sure exactly how long you would have to be off the medications, whichever ones it would be, before you would be back to an immune system that would respond the same as anybody else to the vaccine. So my gut feeling, and no pun intended, would be as far as to say, I would not be looking to change your medications. I would stay on the medications you're on and get vaccinated. But that would be what my thought as an infectious disease doctor, not as a hepatologist. So I definitely would be deferring to what they would be saying.
If patients are curious whether the vaccine took for them, is there a blood test that can be taken that will show the level of immunity developed from the vaccine?
So this has been a very common question, Aaron, and that our recommendation is don't go get tested, because you can get concerning information. And let me try to explain it to you. So there's different antibody tests that I had a woman in our study came back and said, oh, you told me I got vaccine, but I must not have, because the antibody test came back negative. And she showed me the results, and it just said COVID IgG negative. I said, but did they test the S protein or the N protein? And she looked at me and said, huh, which I expected that she was going to say. But the problem is that if you're doing an antibody test against the N or the nuclear protein, it's going to be negative in somebody that just got vaccine. So if you get the wrong test, you're going to get the you get the right answer, but it's not, the answer says it's negative, but what that just means is you never had the viral infection. And so that if you're getting an antibody test against the N protein, that's not going to tell you at all about vaccine. The vaccine stimulates an S or spike protein. Now, the other thing is that we don't know how high a level is sufficient for protection, what's called a correlative immunity. What we know is that in 2 doses of vaccine, 1 week after the second dose of vaccine, both the Moderna and Pfizer vaccine have been around 95% protective. And we know what antibody responses have been induced. And we know that for both Pfizer and Moderna, that the antibodies elicited are far higher than human convalescent sera. But we don't know how high an antibody response we have to be protected. So just as an example, just say the vaccine made an antibody response at 10,000. Well, okay, but maybe all you need is 100 to be protected. We don't know that yet. We don't know the lower limit of antibody that would still keep you protected. And so that's why I'd be nervous about people getting a antibody titer, because I don't know how to interpret it. The only what I could say is positive or negative. And so if either you have antibodies or you don't. But other than that, no one knows what the correlative immunity is or how much antibody you need to be protected. We can just look at the data that we know, which is that 2 doses of vaccine 1 week after the second dose is about 95% protective.
Thank you. There have been stories in the news about severe allergic reactions associated with the vaccine. What recommendations would you give someone who has a history of allergic reactions?
So an allergy to one thing does not convey allergy to something else. And so that you can have an allergy to a penicillin, but as an antibiotic, but you can still get a cephalosporin just fine, or another monobactam or something like that. So an allergic reaction to one antibiotic does not mean that you're going to have an allergic reaction to another antibiotic. The COVID vaccines, that there have been a few people that have reported allergic reactions or allergic symptoms. But if you think about it, is that when we have in a clinical trial, we have 30,000 people in this clinical trial of each one of them. So overall, probably about 150,000 people so far. You're going to have some people that are going to have a stroke. You're going to have some people have a heart attack. You're going to have some people that'll develop diabetes. You're going to have some people that have an asthma attack, just because when you have 150,000 people, that's going to happen periodically, right? And so what you need to be able to do in a clinical trial is to, and that's why we have placebos, is to compare the rates of these adverse events in the vaccine group versus the general community or versus the placebos. So there have been a couple people in Great Britain that had these allergic reactions reported after receiving the vaccine, but whether it was due to the vaccine or it was coincidence again, it's really hard to know. Our recommendation has been is that if you know you have an allergic reaction to a component of that vaccine, you wouldn't receive the vaccine. But I don't know anybody that's going to have an allergic reaction to mRNA, and lipids or fats. So that again is hard. From a medical standpoint, it's not impossible to have an allergic reaction to those things, but it would be, to me, very unlikely. And that, and again, I can just tell you in the clinical trials, we did not see any of those adverse events of the anaphylaxis, the acute severe allergic reaction. We did not see that at all. So I'm not saying it didn't happen to the people in England. I can just tell you is that at this point, we don't see a pattern to really suggest that the vaccine is the culprit.
Do we know yet how long the protection from the vaccines last? Are we all going to need to get the COVID vaccines annually like we do the flu shot?
We don't know. So one of the things is that for the clinical trials is that they're 2 years long. And one of the reasons that they're 2 years long is just try to answer this question exactly, is that so people in the clinical trials are asked to let us know whenever they're having COVID-like symptoms, and then we get them to do a swab, and we check them depending on what their symptoms are, if they need to come in to be seen. And so then we look at the results of the COVID swab to see if they actually have the infection or not. And so we're doing that to be able to get an idea of how long the vaccine does work. And then to be looking at antibody responses over time too, to go back to what I was talking about, the correlative immunity, to try to see if we can get a better idea of how high an antibody response we need to be protected. So the short answer is we don't know how long the vaccine will work. Different from flu, the reason we need a flu vaccine every year is because those H and N proteins on the outside of the virus, so the flu virus, are able to change a lot, and that and still infect us. But if the spike protein changes too much, it might not be able to infect us. So there's a possibility that the coronavirus vaccine would last longer because that S protein, the spike, may be really an integral protein for the virus to be able to infect us. And at least at this point, the variants of the COVID virus still have been neutralized, still have been killed by the vaccines. So that those are hopeful that maybe the vaccine would be a longer period of time, maybe in the range of 3 to 5 years. I don't know. It also may be that we vaccinate everybody at first, we get people get immune, and then we're going to have to target children over time, because that's the new group that's going to continue to get infected, because obviously every virus to a child is a new virus when they're a baby.
After patients receive their COVID-19 vaccines, do they still need to take precautions like wearing masks and practicing?
Yes. And there's two reasons. One is that the full efficacy of the vaccine is not until about a week after their second dose. The other thing is that while there are some data to suggest that the vaccine may decrease the ability for the virus to get in our nose, we don't know that for sure. So the one of the things that we're still not sure about and concerned that could happen is that, okay, so Aaron, you had the vaccine, you're not going to get sick, but there's still the concern is that you could have the virus in your nose and transmit it to somebody else. And that's some of the longer term studies that we are doing to try to see what happens in somebody's nose that has been vaccinated. Do they still have virus that you can find in their nose periodically? And we're actually doing those studies too, so that we're going to have people that have received 2 doses of vaccine, so they're protected. And then we're going to get swabs on them every 2 weeks, regardless if they're well, sick, whatever. You're going to get the PCR for the COVID every 2 weeks on them for a year to see as if they will still have COVID in their nose or not. But so those are the 2 reasons why we still need to have people having protection.
Many AIH patients have been extremely cautious during the pandemic, not seeing extended family or getting together with friends outside their immediate household. Once patients receive the vaccine, can they start to expand their circle a little bit? What is your advice on this?
So I would kind of look at it, it's not just that person, but it's everybody around them too. So that I am hoping that our supply shortage of vaccine will be short-lived, that as we're getting the companies be making more doses, and as we're getting more vaccines online, they will have lots of doses. My thought is that by May or June, that everybody that wants to have vaccine will have the availability of vaccine. I think as we're getting closer to a high percentage of people vaccinated, then we can relax things a bit, but it's going to be a little bit of time. If you're in your family circle and that you've had everybody in that circle vaccinated, so if you're probably fine. And as an individual, once you're vaccinated, we think that it's, like I say, a 95% protection. So that you as an individual, if even have an immunocompromised condition, if you're vaccinated, you should be protected. But we still aren't positive as far as that person can't get it in the nose and potentially transmit to somebody else. And so I would say a limited yes, as far as to be able to relax things a little bit, but I think it's still going to be a bit of time, and time being in the next months and not years. So I don't think I'm having rose-colored glasses. I think I'm being realistic as far as that by next Thanksgiving time, and that for sure is that people will be able to have a normal kind of gathering, and that assuming that we're having people getting vaccinated, like I'm really hoping everybody will.
Unfortunately, we've had a number of members in our community AIH patients actually come down with COVID, they are wondering, do they still need to get the vaccine, and should they wait until everyone else has been vaccinated to go get their vaccine?
So if they're saying about waiting for everybody else, I think that's great that they're thinking of a community as far as putting other people ahead of them, as far as to say, let somebody else go get vaccinated first. Again, like I say, I think that the availability of vaccine is going to increase greatly every week, and that so by summer, I'm really very comfortable that everybody that wants vaccine will have vaccine available. We're still advocating that everybody that got infected still go get a vaccine, and that's partly because there is really a varying of severity of disease. And that one of the things that people talk about, well, you know, I got COVID and then I got it again. I think there's a couple ways that that could happen. One is that the PCR can stay positive for 6 to 8 weeks. So PCR is a polymerase chain reaction, and so when that's the way we're detecting the virus. We're not really culturing the virus. So the PCR doesn't tell us that COVID is alive in our nose. It just tells us that they're finding pieces of the virus. And I can tell you from a common cold that we'll find that for 3 months or more in somebody's nose, even though they're well. So that just because you have a COVID positive does not mean that you have COVID now. You had it sometime in the last probably 6 to 8 weeks, but some people, what has happened is they became infected and then they're getting their doctor to test them for cure. And we're telling people, please don't do that, because it's more confusing than anything else, because you can stay positive for a long time. The other thing is that if you had what people are calling an asymptomatic infection, so that you had the virus in your nose, but you really didn't have cough, fever, congestion, whatever. I'm not sure why somebody got the test if they had nothing, but that those people may not develop the same immune response as somebody that has fevers, chills, cough, ache, because with those systemic kind of symptoms, the virus has probably gotten systemic, and so that you're then having a systemic immune response. Whereas if you're asymptomatic and it's just in your nose, it may not be enough to really get our immune system revved up to make the same immune response. And so that's why we're just saying everybody just go get a vaccine. We don't know how much antibody is necessary to be protective. We do know that 2 doses of vaccine a week after that second dose is about 95% protective. We also have data to show that there's no increased safety risk by somebody being vaccinated after they had COVID. So it's not like I can't get vaccinated because I'm going to get sicker. There's no data to suggest that. And there's actually some data to show that you can boost your immune response with the vaccine, even if you've had COVID before. So for all those reasons is why that I would say, even if you've had COVID, you still should get vaccinated. As far as the timing, we don't know. But what I would say is that from a realistic standpoint, if you feel terrible, I wouldn't tell you to go down and go get a vaccine because you feel terrible. You know, get over whatever, you know, the COVID, and that if you waited a couple weeks, I mean, you know, so the CDC is saying that it's unlikely that you're going to get reinfected within 3 months of having COVID. Basically, those data are just showing that we haven't seen people that get reinfected in that period of time. But a lot of those, again, going back to that reinfection, is I think more of the asymptomatic kind of finding the virus in your nose. That and so that's where some people are saying, well, if I'm not going to get reinfected in 3 months, I'll just wait the 3 months, let other people get vaccinated, and then I'll go get vaccinated because I don't want to take a vaccine from somebody that could use it more than me. And that is nice to hear that people are thinking of other people and worried about other people. But if it's like saying, I don't want to get it because I'm afraid it's going to make me worse, we don't have any data to suggest that at all.
Thank you. That's really helpful advice. We'll wrap up today with just one final topic that a number of people are interested in and have written us about. They're curious, where do immunocompromised patients fall on the vaccine priority list? And do we patients need letters from our doctors to get the vaccine earlier if we are immunocompromised due to the medication we're taking?
So that's a good question, which I don't have a great answer for you at this point. What I would say is that what we're calling as the phase 1B is people with increased risk factors for increased severity disease. Or let me try that again. Phase 1B would be that you have an increased risk of having severe COVID. And so that people that are immunocompromised, specifically T cell, so that you're with the steroids and that, I could see arguing that you're having an immunocompromising condition that could increase your risk of having more severe COVID. That's really state by state as far as how they're rolling out vaccine. Right now, the vaccine is not available for anyone under 16 years of age. And 16 is and above is only for the Pfizer vaccine. And the reason that is because the clinical trials haven't been completed on anybody at younger ages. But we're hoping to have even to 12 before this school year coming up, and that and my hope would be around this time next year, so the first part of 2022, maybe a little bit sooner, we'd have vaccine down to even maybe 3 to 5 years of age. So that and the other thing is that I think that the vaccine shortage is short term, and so these issues as far as who can receive vaccine, I think is going to go away pretty soon. And that it's going to be anybody who wants vaccine, there's going to be vaccine available. So I know it's raising a lot of anxiety because you said, I am so tired of COVID. I am so tired of being in my house by myself. I'm not seeing my friends. I'm not seeing my family. There is a light at the end of the tunnel. We do have vaccines. We are increasing our supply of the vaccines. And I think over the next few months that we're going to have lots and lots of vaccine available. And honestly, my biggest concern at that point, Aaron, is that making people realize the importance of getting the vaccine. So my concern is that we're going to have a lot of people saying, I don't need that. And that's going to prolong the pandemic.
Well, it's great news to hear that we should all be able to get the vaccine fairly soon, and it will be available to everyone. We won't have to worry about getting letters from our doctors and making sure we're getting the vaccine. And it's also good to hear you say to go out and get the vaccine. I'm sure that's something we want to emphasize with our community as well. Thank you for being with us today. We really appreciate it. This has been fantastic information.
You're very welcome. And if there are other questions, I'm happy to follow up with things. Just let me know.
Thank you all, and special thanks again to our guest, Dr. Frenck, as well as our moderator, Aaron Anderson. Per the discussion today, there are still a number of important questions that remain, but overall major progress in the fight against COVID-19 is clear. We still seek to better understand the duration of protection of these vaccines in all people, especially those patients taking immunosuppression medications. It is critical that we all remember that beyond vaccination, continued mask use, hand washing, and physical distancing are important strategies for limiting the spread of novel coronavirus. Lastly, thank you to the collaborators of the AIHA, specifically the Center for Autoimmune Liver Disease and Cincinnati Children's Hospital. We hope you'll join us again for our next webinar. We'll see you then.